Hi, everyone, and welcome. My name is Kathleen Schmaler. I'm a gynecologic oncologist at MD Anderson in Houston, Texas. And it's my pleasure to host a session today for the 2020 Prevent Cancer Dialogue, Prevention, Screening, and Action. This is part one, which will focus on cervical cancer and HPV. I have no conflicts of interest relevant to today's meeting. This session today will go from 12:30 to 2 p.m. Eastern Standard Time. Please be patient with us. This is the first time that we are doing this way. And we have over 1,000 people registered, which is truly, truly amazing. Today's session will include 3 speakers, followed by a question and answer session. There are many ways that you can participate as members of the audience. The first is that you can use the raise hand feature, which is located at the bottom of your screen, to indicate that you have a question or comment, and we will enable the audio so that you can speak. Or you can ask questions and comments in the Q&A text feature that's located at the bottom of your screen. We will go to the raised hands first for your inputs and then to the Q&A text. What I will say is that we'll wait to address any questions and comments until all the presentations have concluded. So the chat feature will be disabled during the first part of this segment. In one way or another, we'll try to answer all your questions, but given the very, very large number of attendees, we obviously may not be able to get to all of you. So we have 3 very distinguished speakers today. The first one is Dr. Ellen Baker, who I have the pleasure of working with at MD Anderson. She's the director of MD Anderson's Project ECHO program, and she leads our cervical cancer prevention and treatment programs in medically underserved regions in the US and globally. Ellen is an internist by training, and she's also, we're very fortunate she joined us after retiring from NASA, where she worked as an astronaut. So Ellen is going to speak to us today about the natural history and epidemiology of cervical cancer and HPV. Our second speaker will be Dr. Rachel Weiner, who is a professor and research director of epidemiology at the University of Washington School of Public Health. She's also an affiliate scientific investigator at Kaiser Permanente Washington Health Research Institute. And she's going to speak to us today about at-home screening for cervical cancer. And then our third speaker today is Dr. Sunny Jung Kim, who is an assistant professor in the Department of Health Behavior and Policy at Virginia Commonwealth University. And she's the co-director of Health Communication and Digital Health Core at VCU Massey Cancer Center. And Dr. Kim is going to speak to us about HPV uptake communication in the social media environment. So a very exciting talk for us today. So with that, we'll go forward with the presentations. And as I said, we'll hold all the questions until the end. Thank you.
Hello, everybody. Good morning, good afternoon, good evening, and thank you for joining us today. I'm going to go through a very high-level overview of the natural history and epidemiology of HPV and cervical cancer. And as I go through this, I'd like you to remember that the epidemiology of this disease can vary depending on when, where, and who we are talking about. I have no financial relationships to disclose. So in the United States now, cervical cancer is relatively uncommon. I think it's about number 20 on the list of cancers affecting women, but this was not always the case. And in fact, before 1940, before 1950, as this line says uterus, it includes uterus and cervical. Cervical cancer was one of the most common cancers in the United States. But through the work of Dr. George Papanicolaou, father of the pap smear, if you will, He discovered in the 1920s that if he could take some cells from the cervix and smear them on a microscope slide and then examine them, he was able to detect precancerous and cancerous cells. And this allowed us to intervene. So when we could detect a precancerous condition, we were able to ensure that these women were treated and they could avoid getting cervical cancer. So the Pap smear over the years in the US and other high-income countries ended up decreasing the rates of cervical cancer by up to 70%. And you can see here 1950 through 2005 in the US and the Netherlands, the rates fell. These are mortality rates. The rates fell very sharply, and this was due to very effective, widespread screening for cervical cancer. And when I say screening, remember, I'm also including the fact that women with abnormal screening tests also received effective treatment. The next great breakthrough came in the 1990s by Dr. Harold Zerhausen, who discovered that the known etiology of cervical cancer was the human papillomavirus. And this allowed for primary prevention in developing an HPV vaccine. In addition, the fact that cervical cancer is an HPV-related disease allowed us to use HPV DNA testing as a screening method. And very fortunately, cervical cancer has a very long, treatable, pre-invasive phase. So we have many years to detect premalignant conditions, dysplastic lesions, and then to intervene to ensure there's no progression to cancer. HPV is the most common sexually transmitted disease. It is asymptomatic. The initial infection occurs in teenagers or young adults. In fact, half of all new HPV infections are in women 15 to 24 years. 80% of people will have an HPV infection at some point in their life, and globally the prevalence is about 12%. Currently, about 80 million people in the US are currently infected, and about 14 million new infections occur each year. Very fortunately, a small percentage of these will develop precancerous lesions, and an even smaller percentage will develop invasive cancer. There are more than 100 HPV genotypes, and at least 14 of these have been defined and considered to be high risk for development of cancer. Types 16 and 18 are the worst offenders, causing 70% of cervical cancers, but also causing and associated with 5 other HPV-associated cancers: anal cancers, oropharyngeal cancers, penile, vaginal, and vulvar cancers. HPV type 6 and 11 are not oncogenic, but cause significant morbidity in the form of genital warts and also recurrent respiratory papillomatosis. In the US, there are about 44,000 new cases of HPV-associated cancers each year. Approximately 13,000 of these are cervical, and almost 20,000 are oropharyngeal. About 35,000 of these can be directly attributed to HPV, and 32,000, or about 3/4 of them, can be prevented with the nonavalent or 9-valent HPV vaccine. Looking at it another way, in women, half of the HPV-associated cancers are cervical, and that means half are not cervical, or anal, vaginal, oropharyngeal, and vulvar. In men, the overwhelming majority of HPV-associated cancers are oropharyngeal. And just a side statement about oropharyngeal, it is now the most common HPV-associated cancer in the United States, and it is one of only 5 cancers in the last 30 to 40 years that have shown an increase in incidence. So what is the natural history of high-risk HPV? Well, fortunately, 90% of people who are infected with HPV will follow the path on the top of this chart. That is, within 6 months to 2 years after initial infection, they will clear the HPV infection and it will not cause any disease. And for reasons we don't understand, a smaller percentage of women will follow the the path on the lower part of this chart. That is, over 2 years, they will have a persistent HPV infection. They will not clear it naturally. And over the course of time, some of these women will develop high-grade precancerous conditions, perhaps over 3 to 5 years. A percentage of them will end up clearing the virus naturally, but those with high-grade dysplasia over subsequent 10 to 20 years will go on to develop invasive cancer. And looking at it on a more histologic level, the HPV infection attacks the basal membrane of the squamous epithelial layer, primarily in what we call a transition zone. This is an area of the cervix where two different cell types come together at the endo-ectocervical junction. There is a lot of cellular activity here. And once the infection takes hold, viral oncoproteins are expressed with this persistent infection, which also results in disabling or interfering with tumor suppression genes. So we have many opportunities to intervene and prevent cervical cancer with primary prevention, delivering the vaccine prior to exposure. And then after this, we have an opportunity to screen women on a regular basis, identify premalignant or precancerous changes, and provide treatment so these don't progress to cancer. In terms of the where, within the United States, you can see the darker blue areas are where the incidence and mortality rates are high, above the national average. Approximately 300,000 women now are living with cervical cancer in the US, and where I live in Texas, the incidence and mortality rates are higher than the US average. On the left, you see the dark red areas where the incidence rates are higher than the state average and the national average, primarily along the border with Mexico and then in the northeast part of the state, and the dark blue areas on the right where the mortality rates vary. It also matters who you are. So the number of new cases vary by race and ethnicity. Approximately 13,000 new cases in 2019. The national average is about 7.3 cases per 100,000 women, but it's higher in Black women and it is higher in Hispanic women. In addition, mortality rates will vary by race and ethnicity. And Black women and Hispanic women, again, and Native American women have higher rates than the national average. And you can probably come up with some good theories on why this might be so, and perhaps it has to do with access and resources available to these women. Just as an overview, it is the most frequently diagnosed cancer among women ages 35 to 44. With a median age at diagnosis actually a little bit below the age of 50 and a median age at death of 58. And probably the most common reason for women developing cervical cancer at a late age is because they were not adequately screened and treated at a young age. This is a preventable disease. The costs involved with prevention and treatment are fairly significant. We do millions of screening tests each year. A significant number of these, 2 to 3 million, will be abnormal, and these women with abnormal tests will require additional visits, repeat testing, and about 350,000 of these women will have precancerous lesions that require treatment and follow-up. So the cost of prevention and treatment of HPV-related disease in the US is about $8 billion a year, most of this for screening, most of this for follow-up and treatment of abnormal results. Where you are matters globally. Around the world, more than 500,000 women are diagnosed each year with cervical cancer, and more than 250,000 women die. And you can see the regions most affected are sub-Saharan Africa, some regions in Latin America, and also Asia. Every year, every day, 850 women die from cervical cancer. And it is the number 1, 2, or 3 most common cancers in 146 countries around the world. It is the #1 cause of cancer and cancer-related deaths in many countries, particularly in sub-Saharan Africa. Remember, this is a preventable disease. No women should develop this disease, and certainly no women should die of this disease. Another way to look at it, the blue bars on the left represent incidence, the red bars on the right, mortality, and you can see at the top of this chart, Southern and Eastern and Western Africa have very high rates of cervical cancer and high mortality. And the graph narrows down at the bottom with North America, Australia, New Zealand, Europe, where the rates are fairly low and the mortality is extremely low. The good news is we can prevent this disease. In spite of what you might have read about the HPV vaccine, it is a very safe vaccine. It is non-infectious, non-oncogenic. You cannot get HPV from this vaccine. It produces much higher levels of neutralizing antibody than a natural infection. And in fact, half of the women who have an HPV infection will have no antibody response. So the vaccine produces a very vigorous, very protective antibody response. Antibodies prevent basement membrane binding of the virus. And most importantly, the vaccine is not effective to treat an existing infection. So it's extremely important to deliver this vaccine prior to exposure to HPV. And I'll mention in a little later, it's important to give it to younger children who develop a much stronger immunogenic response than older. Currently around the world, there's 3 types of vaccines available: the bivalent vaccine protecting against 16 and 18, the quadrivalent also protecting 16 and 18, and the nonavalent protecting against 7 high-risk HPV types as well as 6 and 11. The only vaccine available in the US is the nonavalent. The other vaccines are available around the world, although there is currently a global shortage of the HPV vaccine. In the US, the recommendation is that preteens should finish their vaccine series by the 13th birthday. It can be given as young as 9 years and as late as 26, and is actually also approved up to age 45. It's important to think about immunizing boys as well. As you saw in my earlier slide, oropharyngeal cancer, which is more common in boys or men than women, is an HPV-associated disease and is now the most common HPV-associated disease in the US. So dosage and scheduling, 2 doses if the vaccine series is started prior to the 15th birthday. And this is because younger children have a much stronger immunogenic response and the protection is sufficient with just 2 doses. 3 doses if the vaccine series is started after the 15th birthday. And this is in children with no other complicating conditions. There are several ongoing studies around the world now to look at the effectiveness of a single dose, which would be, of course, a tremendous advantage. A 1-dose vaccine would be way preferable, but the studies are looking to see what the immunogenic response is and how long the protection lasts. Again, in spite of what might be out there on the internet, the HPV vaccine is safe. Currently, more than 3 million doses of the vaccine have been given worldwide, and the vaccine adverse events are what you might expect with any vaccine. But there are no serious adverse events related to the HPV vaccine. Since the vaccine's been available since 2006, we are now able to notice the reduced incidence of higher grade dysplastic lesions in vaccinated women. I give just a few examples here: Denmark, Scotland, and the US, where women who are vaccinated are showing much lower rates of high-grade dysplasia than unvaccinated women. In addition, in Australia, which has very high vaccination rates, they've seen a remarkable reduction in genital warts. So it will take another decade or so to be able to measure the reduction in the incidence of cervical cancer among vaccinated women. But for now, CIN2-3 higher grade dysplasia serves as a surrogate marker for development of cervical cancer. This is a vaccine to prevent cancer. So secondary prevention involves screening, and I'm not going to go into the details of the different screening protocols. There are many national and international groups that have a variety of recommendations for what the screening regimen should look like, using PAP HPV, and using high-risk HPV only. But I will say that we will still need screening, even if we have higher vaccination rates. The vaccine uptake has been relatively poor in the US. It's improving so that now a younger cohort from ages 13 to 19 are about 70% fully covered. Around the world, fewer than 5% of age-eligible women have been vaccinated. In addition, the existing vaccines don't cover all HPV high-risk types, and they don't treat pre-existing infections. So for the foreseeable future, screening will be necessary, and it's still recommended after vaccination. Just a word or two on HPV testing as a screening method. HPV DNA testing is a very, very sensitive way to detect high-grade dysplastic lesions. And this is a little bit of a busy chart showing several studies. And what this chart is showing is the ability of PAP versus HPV testing to identify women who have a high-grade dysplasia, or what we call CIN2. So 95% of these women will be identified through HPV testing. Only 50% will be identified through PAP testing. And what this means is if 20 women come into the clinic and they have a high-grade lesion, a CIN2 lesion, 95% of them will be identified as such with HPV testing, but 50% of the PAPs will be negative. And so it will give women who have PAP testing only a false sense of security. And another way to look at this is following a negative HPV test, the risk of developing high-grade dysplasia in the subsequent 5 years is very low, and those are the dashed lines in the bottom. However, with cytology, you are going to miss a significant number of women who have a high-grade lesion. And so half of those women might have a negative test and might go on to develop higher grade lesions and progress to cancer. So HPV testing is a very sensitive test and a very good test. It's used in the US along with co-testing, but is also approved as an independent test for cervical cancer screening. So in the U.S., what should our tactics be? And I say in the U.S., but these are similar tactics and strategies around the world. Certainly scaling up screening, doing a better job of screening with a broader reach. And when I say screening, remember, I'm also including treatment of pre-invasive disease. Scaling up screening will get us to the elimination goal much faster than the vaccination. Remember, vaccination will take a few decades for the impact to be measured, and that is the reduction of cervical cancer. So a 13-year-old who's vaccinated might not be measurable until they are, let's say, 30 years, 40 years later. But screening up, scale up, and treatment will get us there faster. And in fact, in just a matter of several years, we can see a very, very rapid decline in reduction of cervical cancer. And I'll end with this. Many of you are probably familiar with the WHO Director General's call to action to eliminate cervical cancer as a public health problem. And the goals are to vaccinate 90% of girls by 15 years of age, to screen 70% of women around the world with a high-quality test, an HPV test at age 35 and 45, so at least twice in her life. And of those women who have a positive test, identify them and ensure that 90% of them receive the proper treatment for precancerous lesions or invasive cancer. And when he says eliminate cervical cancer, the threshold is to reduce the rates to fewer than 4 cases per 100,000 women per year. So these are our new goals. These are achievable. We have all the tools that we need to eliminate cervical cancer. Let's start with vaccinating our kids. They are children, but they do grow up. So let's move forward together and make some progress. Thank you.
Hi, my name is Rachel Weiner, and I appreciate the opportunity to talk to you about at-home screening for cervical cancer as part of this virtual Prevent Cancer dialogue. Now, each year in the U.S., there's over 12,000 new cases of cervical cancer that are diagnosed. And a major risk factor for cervical cancer is underscreening. And in the U.S., roughly 1 in 4 women are not up to date with guideline recommended screening, or they've never been screened at all. And more than half of the cases that are diagnosed in the U.S. are diagnosed in these underscreened women. And of course, now underscreening is further being exacerbated in the context of the current COVID-19 pandemic, with the number of cervical cancer screening tests down 68% nationally compared to pre-COVID-19 levels. Now, there are many documented barriers to cervical cancer screening, even in settings like the U.S., where screening has been widely available. These include lack of time, transportation difficulties, difficulties finding childcare, not having access to health insurance, living far from a clinic or having difficulties scheduling an appointment. Some women have fear or embarrassment about receiving a pelvic exam for a clinician or have had negative experiences in the past, and low health literacy. And again, with the current pandemic, access to routine preventive services, fear of exposure from going to a doctor's office, these are additional barriers that we're seeing. Now, there are 2 tests that are used in cervical cancer screening. These include Pap tests, which look for abnormal cells, and HPV tests, which detect the presence of the virus that causes these abnormal cells. And these 2 tests are used alone and in combination with different screening strategies. Now, what I'm showing you here is the 2018 U.S. Preventive Services Task Force Cervical Cancer Screening Guidelines for 30 to 65-year-old women, because there were 3 different options now for women in this age group. Pap testing every 3 years, Pap and HPV co-test every 5 years, or this third option, which was a new strategy introduced in 2018 in these guidelines, which was testing for HPV only, also referred to as primary HPV screening every 5 years. Now, all 3 of these options still involve going into a clinic for a pelvic exam and having a clinician collect a sample of cells from the cervix. Now, with primary screening for HPV, the sample is first tested for HPV. So with this strategy, if the sample tests positive, a Pap test may then be run on the same sample to determine the appropriate follow-up plan. Or if the sample tests positive for HPV 16 or 18, which are the types that are considered highest risk for cervical cancer, the women may be referred for a diagnostic colposcopy. However, if the sample tests negative for HPV, she can safely return to a 5-year routine screening interval. Now, what's exciting is now that primary or HPV alone screening is a guideline-approved option for cervical cancer screening, it really opens the door to HPV self-sampling strategies. Now, that's because unlike Pap tests, which have to be collected by a clinician, women can accurately collect their own samples for HPV testing. And so if HPV samples could be self-collected at home with in-clinic follow-up only on women who test positive, the need for in-clinic screening could be eliminated for a majority of women, which would result in fewer clinic visits, less inconvenience, and greater reassurance for women who test HPV negative. Self-collected samples for HPV testing have great potential for reducing disparities in cervical cancer screening by offering an acceptable alternative for women who delay Pap screening due to lack of time or inconvenience or fear or embarrassment about receiving a pelvic exam from a clinician. Now, there have been a number of studies conducted in the US that have demonstrated that self-collected sampling for HPV testing is feasible and acceptable to women, and that there is good agreement between clinician-collected and self-collected samples for HPV testing, and comparable performance for detecting precancerous cervical lesions. And furthermore, there have been now several population-based trials in countries with organized screening programs demonstrating that mailing self-sampling kits to women who are not responsive to standard invitations to attend Pap screening is effective at increasing cervical cancer screening participation rates. And importantly, these trials have also showed that compliance with follow-up after a positive HPV test is high, and there's a higher yield of cervical precancers. And based on the success of these trials, several countries, including Australia and the Netherlands, now include HPV self-sampling options for underscreened women as part of their regular cervical cancer screening programs. Now, from 2014 to 2018, I conducted the HOME trial with a great group of colleagues from the University of Washington, Kaiser Permanente Washington Health Research Institute, the University of Texas Southwestern Medical Center, and the University of California at Davis. This was a pragmatic trial of mailing home-based HPV self-sampling kits to underscreened women within a US healthcare system. And this was the first time that this strategy had been tested in a US healthcare system. So the trial was conducted at Kaiser Permanente, Washington, which is an integrated healthcare delivery system. And what we did is we used electronic medical records to identify 19,851 women between the ages of 30 and 64 years who were overdue for routine cervical cancer screening. And the goal was to compare the effectiveness of two programmatic approaches to increasing cervical cancer screening. Women were randomized to one of two arms: usual care only, which at Kaiser Permanente, Washington, consisted of annual Pap reminders and outreach from primary care teams. The other arm got the same usual care, but they were also mailed an unsolicited HPV self-sampling kit. Women were followed for up to 18 months, and the trial was completely integrated into the clinical delivery system. And so we tried to mirror as much as possible the strategies that the health system would use for this sort of approach if it were to be implemented into standard practice. And this is a picture of our self-sampling kit and the illustrated instructions that came with the kit. We used simple cotton swabs and a dry transport tube for collecting the sample, and then the sample was mailed back to the laboratory for testing. So 9,960 women were randomized to the mailed kit arm, and 9,891 were randomized to the usual care only arm. Screening uptake was tracked through electronic medical records for 6 months. So women in the intervention arm, they could choose to either return a kit or attend in-clinic screening. With this hybrid approach, just over half of those screened in the mailed kit arm chose in-clinic screening. 12% chose to return a kit. Kits were tested with the Roche Cobas assay, and aligned with US national management guidelines, women who tested negative for HPV or positive for HPV 16 or 18 were considered fully screened. However, women positive for other high-risk HPV types were required to complete reflex Pap for co-testing in the clinic in order to count as fully screened. And overall, 26% of women in the intervention arm versus 17% in the control arm were screened, which corresponded to a 51% increase in screening uptake. Diagnostic outcomes, so those are the precancers or the CIN 2 or greater, were captured for up to 6 months post-screening. So some of the women had test results that warranted colposcopic referral. You can see that not everyone who was referred for colposcopy actually went for colposcopy, and that's certainly a gap. And in fact, only about 70% of women overall who required follow-up in the clinic actually received it. And we'll discuss that later as one of the gaps that would need to be addressed. But we detected a total of 12 CIN 2+ cases in the intervention arm, including 2 in women who self-sampled and 10 in women who chose in-clinic screening, and 8 cases of CIN 2+ in the control arm. And that corresponded to a non-statistically significant relative risk of 1.49. And we took this a step further. So we tracked screening uptake, we tracked diagnosis of cervical precancers, and we also tracked treatment of those precancers for up to 6 months post-diagnosis. Now, all 12 cases were treated in the intervention arm, and 7 of 8 cases in the usual care arm. And that corresponded to a non-statistically significant relative risk between arms of 1.7. Now, I'd like to take a minute to focus on the HPV testing results in these 1,200 women who used the self-sampling kit. So about 3% of these women tested positive for HPV 16 or 18, which meant they were referred directly for a diagnostic colposcopy. And 9% tested positive either for other high-risk HPV types, or for less than 1%, they had an unsatisfactory self-sampling result. And both of these outcomes required in-clinic visits to complete the screening, either with a PAP or a PAP HPV co-test. And the remainder, 88%, tested negative for HPV. So with in-clinic screening, which is represented with this pictogram on the left, you have 100 out of 100 women are needing to come into the clinic to get that screen. And just like with home screening, about 3 out of 100 will require additional immediate follow-up with a colposcopy. Whereas with a home-based screening approach, 88 out of 100 women will avoid a clinic visit altogether. 9 out of 100 will need to come into the clinic to do a PAP or HPV test. And then similar to the in-clinic approach, 3 will need immediate colposcopy. So with the in-home screening approach, the need for a clinic visit could be removed for most women. Now, part of the same trial, we were interested in learning about women's experiences with using the test kits and their experience with positive results and following up through using the clinical delivery system. And so what we did is we interviewed a subset of women who had positive kit results to understand their perspectives and information needs following a positive test. We invited 75 women, 46 agreed to be interviewed, including 38 who had completed all of the recommended follow-up and 8 who did not complete all of the recommended follow-up after their positive results. And we identified several themes that had to do with different domains. So the first was reaction to the test kits. And a theme was that women found this to be a very convenient method. And some representative quotes here. I actually thought it was pretty cool. You could do something like that at home and just mail it in. A private way to take a test and find out about something. It didn't seem daunting to me or overwhelming. On the other hand, we learned things about reactions to positive test results. And one of the themes that emerged is that women felt anxious and they felt a sense of urgency to follow up and discuss the results with their provider. So one woman said, I had a follow-up phone call from a nurse 3 days after getting the email. I had nobody to ask questions of, so my lack of information caused panic. Another woman said, it made me feel like I needed to go in and see my doctor right away and have another test, which I did. Another theme related to reaction to positive results was poor understanding of what the results meant and subsequent information seeking. So one woman said, I didn't understand what I was reading on the internet, so I made an appointment with the doctor. And another woman said, once I got the results online, I did look on the internet to kind of explain, because half of it said negative and the other part said positive, so I thought, what in the heck? And that has to do with the fact that with the test results, you might see that you're negative for HPV 16, negative for HPV 18, positive for other high-risk types. That's how the results are reported out, and that can be confusing. Another theme that emerged was being surprised by a positive result because the women perceive themselves to be at low risk. One woman said, so when I tested positive, I'm 60 years old. It's not like I'm running around. I've had the same partner for 27 years. I was quite shocked when she told me it was an STD, and I was about floored. Another said, I just had questions from beginning to end. I've only been married to one person. Why is this showing up now? I don't get it. Another theme that emerged had to do with understanding about different screening strategies and follow-up strategies. So one theme was concern that HPV self-screening is inaccurate when the PAP is normal. And that has to do with the fact that women who had a positive result, and if it was negative for type 16 or 18, so they weren't being sent directly for colposcopy, but they were being referred to come in for a PAP test, sometimes that PAP test would be normal, which is something that would happen with a co-test. It's not uncommon at all to have a positive HPV test and a negative PAP test, but it's a little confusing to women in the scenario where you do a part of the test at home, the HPV part, and that's positive, and you come in for the PAP part and that's negative. So one woman said, if it's contradictory to my regular PAP smear, or maybe it's more specific, I just don't understand why they were different. Another woman said, I would rather them, other patients, go through a doctor than to use your kit, because I wouldn't want them to go through what I went through. But if it worked and you guys got it better, or found out it was a tech or a machine problem, then yeah, I think doing it at home is so much better than going to the doctor, but not with the kit the way it is right now. So definitely room for education there. And then another piece that we did as part of this trial is we mailed surveys both to women who completed the kit and to women who did not complete the kit, so that we could understand HPV and cervical cancer knowledge and perceived risk associated with returning a kit, and also learn more about kit user experiences. So we wound up getting surveys from 120 kit returners and 115 non-returners. So in terms of their knowledge about HPV and cervical cancer, we didn't see really any significant differences between women who did and did not return a kit, but we did identify general areas where women were well-informed versus less well-informed. So in terms of areas that women seem very knowledgeable about, most of them knew that HPV always has visible signs or symptoms. They were aware of the link between HPV and cervical cancer and aware that HPV is sexually transmitted. They knew that it was not true that, if you have HPV, you'll definitely get cervical cancer. But we did identify some gaps in knowledge. Most women did not know that most sexually active people will get HPV at some point in their lives. Most did not know that HPV can go away on its own without treatment. And another gap that the majority did not know is that risk of cervical cancer is low with a negative HPV test. In terms of the kit user experiences, most women felt the kit was easy to use, it was convenient, didn't cause pain, but the gaps were that women were not as sure that they were able to self-collect a good sample on their own, and they weren't sure that they trusted the self-sampling results. So to summarize the main findings from our home trial, so we found that mailing HPV self-sampling kits to under-screened women increased screening overtake by about 50% compared to usual care pap reminders alone, with no significant difference in detection or treatment of cervical cancers. Women found this to be a patient-centered approach. They found the kits convenient and easy to use. But we did identify some areas for improvement that could be targeted with future interventions. So definitely there's a need to improve patient education to address concerns about women's ability to use kits correctly and distrust in the test results. And related to the fact that not everyone who tested positive with the kit came in for follow-up, it would be important to work on closing systems gaps and improving patient and provider education to increase adherence to diagnostic follow-up after an HPV positive kit result. So some of the future steps. So what are potential implications for implementing primary HPV screening strategies that incorporate home-based self-sampling? And really, how do we engage the hardest to reach women in cervical cancer screening? So even in our trial, even though there was a 50% increase, about 3/4 of women still remained under-screened. And I think a really important question is, how can HPV self-sampling be used to scale up cervical cancer screening in low and middle income countries? And I want to just spend the last couple minutes talking about that. So cervical cancer screening programs have been extremely difficult to implement in low resource settings. And most women in low and middle income countries have not been vaccinated with HPV, so they're not getting that benefit. And those unvaccinated women will generate an expected 35 to 40 million cervical cancers over the next 65 years. And that's data from modeling studies. In 2018, the World Health Organization set goals for cervical cancer elimination that include targets for vaccination, screening, and treatment milestones to reach by 2030. So these include vaccinating 90% of girls less than 15 years of age, achieving 70% once in a lifetime at least screening coverage in women aged 35 to 45, and ensuring that at least 90% of detected lesions are treated. Now, scaling up screening could potentially be improved by incorporating HPV self-sampling, but this will require an organized approach tailored to country-specific needs. And this last figure here that I'm showing you is a figure from a paper written by staff at PATH, which is the Program for Applied Technology and Health, that outlines thinking on incorporating HPV testing into the cervical cancer screening process in low and middle income country settings. And it's depicting theoretical timelines and bottlenecks that might occur. And the authors suggest that scaling up screening in low and middle income countries could be substantially improved through HPV self-sampling approaches, HPV testing, improved triage and managing screen-positive women with accessible treatments. And also another thing they point out is that the implementation of these tools will require basic minimal health information for traceability of women, provider training to carry this out, community education, operational management, and quality control. And that strategies would need to be tailored to individual country settings. So with that, I'd like to say thank you, and I look forward to the panel discussion.
Hi, today I will be presenting on HPV uptake communication in social media environments. So today talk, I will go through some of the background information about how social media can be beneficial or provide opportunities for risk communication for behavior change research. And in the next slide, I will present phase 1 study using virtual focus groups to understand people's perceptions and attitudes and psychological barriers about HPV vaccination, especially in rural areas. In phase 2, I will be presenting a randomized experimental study conducting message testing experiments. And in phase 3, I will provide a brief summary about how we use social media for campaigns for HPV uptake in rural areas. And I will finish my presentation with future directions and questions. So this project was a 1-year project and contained 3 different studies. And first we start with environmental scan study, which we did through virtual focus groups using Facebook. So before presenting the method, it is well known that more than 79 million Americans are infected with HPV, and there are more than 30,000 people developing HPV-related cancers in their lifetime. And also, we know that HPV causes as many deaths as measles did in the pre-vaccine era. So this is the public health problems, and the current HPV vaccine prevents up to 93% of cancer cases caused by HPV, but the rate of HPV vaccination in the US nationwide is 49%, which lag far behind other countries, and no state had reached the Health People 2020 goal of full vaccination of 80% rate of adolescents vaccination rates aged between 13 and 15 years. So with that, there's still a lot of work to do to disseminate information about this HPV vaccination and also provide useful information about the vaccine, the vaccination rates, and etc. And also we found that the HPV vaccination rates among certain populations, such as adolescents in rural areas, are not as high as other adolescents vaccines. And also we learned that parents who decline the vaccine maintain mixed and negative or ambivalent attitude toward the HPV vaccination. And some of the negative or ambivalent attitudes or lack of knowledge or misunderstanding about this HPV vaccine may come from exposure to social media or exposure to information from other types of media. And if we go to social media, there are a lot of misinformation and also some very negative information, misinformation about HPV vaccine, and there are strong communities really posing anti-vax statements. And so there's a lot of misinformation on social media. And for example, one article from the Washington Post report that a teen who defied anti-vaxxers says that she got false information from social media. So because of this, the inundation of misinformation on social media, if parents are exposed to this communication noise, and if they are exposed to this misinformation repeatedly over time, it may influence their attitude, and it may influence their belief system and also knowledge base, in turn, which can also influence people's not following the guideline for HPV vaccinations. So some of the barriers why parents are not vaccinating their children against HPV may come from psychological barriers. So the goal of the study of this project was to really identify psychological barriers or facilitators why parents in rural areas have or have not vaccinated their children against HPV. And with that goal of the project, we use social media as a way to conduct a series of studies because social media platforms provide opportunities. For example, social media researchers, by using social media, researchers can reach out to underserved populations, for underserved populations and also patients who are geographically distant. And also we can encourage user engagement, and also we can have two-directed communication, two-way communications, and researchers can also provide social support, informational support, or emotional support through social media. And also social media is very cost-effective compared to other mass communication media environments. And also we can measure naturally occurring communication among patients or among underserved populations or among other population of interest. And also social media enable researchers to build up and scale up intervention content and method and outcomes. With these benefits of using social media, we conducted 3 different studies simulating social media environment. First, we conducted a series of virtual focus groups to understand the main themes that may be useful for developing message campaigns later. So first question was, would it be feasible to use social media to reach out to parents in rural states such as New Hampshire and Vermont? So we conducted a very quick screening using Facebook advertising features. And according to US Census Bureau, there were more than 1.5 million adult population in New Hampshire and Vermont. And when we use social media, estimate the number of people that we can reach, we learned that we can reach out to up to 1.4 billion people, adults living in New Hampshire or and Vermont states. So we understood that using social media will be feasible to reach out to parents in these rural areas. So with that, we also developed focus group questionnaires. We developed 6 different sets of questions in a structured format, and we use the same consistent format across all the virtual focus groups. And we disseminated those focus group postings via rural and urban area zip codes on Facebook. And after conducting each focus group question, we also data mined user comments for thematic analysis. So to produce a set of questions, we use this behavior prediction model, which is called an integrated model behavior prediction by Bisbane and Iser. This model basically explains all the important constructs and concepts that may explain someone's behavior change. So this was the structured focus group question. As you can see, all the focus group questionnaire have a structured format. First, we use a very neutral source, doesn't reveal any association or organization information. We start with greetings and background information, introducing about the HPV vaccine recommendations by the CDC. And after that, we proposed a set of questions that were developed by the model. And at the end, we also provided a survey link for those who are introvert or for those who don't want to make public comments on Facebook. So the people who are more willing to provide their thoughts and opinions in a private setting, they were able to access the survey to provide their thoughts about these questions. And also we displayed a disclaimer informing people that these data under the user comments will be used for research purposes. And also we always use the image that were congruent with the context. So this is an example. This is one path that explains behavior change, and these are some of the important psychological constructs. So we build research questions asking these psychological constructs. For example, we measure their belief system. Do you believe that boys and girls in this age range should get the vaccine? So we also measure their motivation level by asking, would you be motivated in following this recommendation? So these were the embedded questions in this structured format. So these are where people see these structured format questions. So we have 6 different sets of questions using the model. So this set of questions, this is an example, ask people's response efficacy, asking, do you believe that HPV vaccine will protect your children against warts and cervical cancer? So we follow these pathways explaining behavior change and generate these constructs, generate virtual focus group questions based on these constructs, asking people's skills and their knowledge level. And also we ask people to share their any perceived environmental constraints or barriers. So for the Facebook advertisement features, we use a geo-targeting feature to target parents living in New Hampshire and Vermont. We extracted from the nationwide data set. We know that there are 609 zip codes in New Hampshire and Vermont. So we use this zip code to target parents living in these areas. So we also control for the audience targeting. We include everyone living in those zip code areas, New Hampshire and Vermont. And also we only ask for adults. So these were actually 18 or 18 and above, and we target both men and women. So during those focus group questionnaires, focus groups, while we are running the series of focus groups, one at a time, we very closely monitor the data, user comments, and we hit any comments that were not related to the topic. And we also hit anti-vaxxers who came repeatedly to disseminate very strong negative and kind of aggressive opinions about the HPV vaccines. And also we control for trolls and attack or swear comments. But the purpose of this focus group was to observe people's thoughts and observe people's opinions. So there was no intervention provided, but we just conducted observation studies. So also these 6 different Facebook advertisements proposing those different set of questionnaires were randomly distributed over time. For data analysis, after finishing the final set of focus group, we extracted all the user comments, which were 727 user comments. And we also used pre-validated coding schemes that propose 23 different sub-themes and main themes about HPV vaccinations. And also we conducted linguistic analysis using the more than 12,000 words from the focus groups. So these are some of the coding scheme, 23 themes that emerged from the focus group, our focus group comments. So as you can see, these are all the comments that came up, but there were more salient themes, which are these 5 most salient themes from focus groups. The first theme was safety. People's comments were about safety concerns and side effects and risk, perceived risk about the vaccine. And there was a lot of comments indicating some distrust to the system, healthcare system, and also some of the themes were about distrust about the vaccine effectiveness, and also there were a lot of comments misstating about the facts about the vaccine and also about the HPV disease. We extract these 5 themes. Those are the most 5 salient themes. And what we learned from this virtual focus group was that using social media platform were effective in engaging parents in hard to reach geographic areas for discussion on HPV vaccinations. So, and also by using this method, we were able to collect communication strategies and themes that might be useful for public health communication campaign strategies. But we also learned that it is very important to monitor focus groups in real time because there are constant trolls, and also there's a lot of swear comments and bad comments, unrelated comments. So it was very important to have live monitoring. And although we set the geo-targeting features through those focus group advertisements, but there were no validation tools for confirming the locations. So that was some of the limitations of this approach. But based on what we learned from focus group, we developed the messages to test message effectiveness. So this is the phase 1, but now we are in phase 2. So we first developed a number of messages that fall under each theme from the focus group, and also we conducted a randomized message testing experiment. So this is snapshot of the message testing experiment stimulus material. So to develop the messages, we use principles from communication and persuasion. So for each theme, we developed 5 messages for each theme. The themes that we learn from focus groups. And we use persuasion tactics, such as we use emotional appeals in the messages, and also we use rational appeal, which means that providing some science-based information. And also we use concordance, we maintain the concordance between the image and the text. And we always use the neutral source, and we also use recency facts, which means that providing the target persuasion statements at the end, promoting the health behavior change, which is vaccinating their children against the HPV. So, and also for the message testing experiments, we control for the length of messages across different stimulus materials, and also we simulate social media environments within the message testing experiment. So this is the stimulus examples of stimulus materials. These all look like Facebook posting, but this is actually a set of messages that we tested for within the message testing experiment. So this is an example for theme 1, theme 2, theme 3, 4, and 5. So these were some of the examples of stimulus materials. This is a study logistics within the message testing experiments. So we recruit people, parents through social media and crowdsourcing using mTurk and Facebook advertisements. So we conducted a screening for eligibility criteria, and if people provide their consent and if they are eligible, then they were asked to answer pre-test survey questionnaires, measuring demographic information, environmental factors, and prior knowledge about the vaccine, HPV, and also the level of issue involvement, and also people's attitude toward the HPV vaccine, and also HPV vaccine status of their children. After finishing the pre-test survey measures, or parents were randomly assigned to one of the conditions, one of the message stimulus material. So the theme 1, 2, 3, 4, 5. So each team had, as I said, each team had at least 5 messages, and for each message we recruit more than 30 eligible parents for each message to have enough power for data analysis. So people were randomly assigned to one of these messages, but at the same time we had a control group, which means that we also provided control group materials that has nothing to do with the HPV vaccine. The control group message was about e-cigarette and vaping. So people were assigned to one of these stimulus material. And after reading this stimulus material, people were asked to answer post-test survey measures. We asked measure manipulation checks. Also, we measure attitude toward the HPV vaccine, people's behavior intention to vaccinate their children against HPV, and also we measure message effectiveness and persuasiveness, and also we measure socioeconomic status. So these are the flow chart of how many people were recruited, how many people we recruit. So we recruit more than 1,700 people, more than 1,600 people. They screen for eligibility. 24 declined to consent, and 631 people had no children, and thus they were not eligible. And there were 42 people who dropped during the screening process. So we had 1,016 eligible parents who provided consent. During the time before random assignment to the messages, 18 people dropped from the random assignment before the random assignment. But across those theme conditions, we had almost equal distribution of people for each team and also for the control group. And also before the finishing starting the post-test survey, there were 7 people dropped, but at the end we had 991 parents who finished the entire experimental surveys. So that is the number that we use for data analysis. So this is just a snapshot of the path analysis showing which things were effective in change people's behavior intention to vaccinate. So the unit of analysis is theme. So each team, this is 1, 2, 3, 4, 5, and this is a control group, which was used as a reference group within this test model. What we found was that all these 4 teams out of those 5 were more likely to increase behavior intention to vaccinate, in part due to the increased positive attitude toward vaccine. So that was the story that we learned from this thematic analysis, the theme-based path analysis. And also there was no messages, and this is just theme level, but also we conducted the analysis using messages as the unit of analysis. And what we found was that there was no messages that generated any adverse effect or boomerang effects. So, and based on the message persuasiveness, we generated, we finalized a set of messages that to be used for social media campaigns, the real world campaigns. So for each team, we selected a set of messages that had highest scores on message effectiveness assessments. So these are the messages that were finally selected as the candidates for social media campaigns. So we had at least 1 message for each team. So now we conducted message experiments to detect the best candidate messages for social media campaigns. So now in phase 3, we implemented and disseminated those HPV campaign messages that were selected from this previous stage of the studies. And also we implemented evaluation strategies for campaign assessments. We conducted, also we embedded online surveys within each advertisement so that people can also finish their online surveys. And also we extracted ad performance data, and we also collected user comments within each social media campaign post on Facebook. So now we are phase 3. This is about HPV uptake social media campaign. We use Facebook because it has as I said, it provides some benefits. We can do rapid prototyping for campaigns, and we also can control message exposure and frequency, and we can also deliver these messages over time in a cost-effective manner. And also we can coordinate the message the campaign timeline schedules in advance. And also we can target specific group of audience. The target audience of this campaign were people living in rural states, and so we also use geographic targeting and also personal interest-based audience targeting on Facebook advertisement. So each Facebook advertisement, now we are implementing campaign messages, but we disseminated pre-validated, pre-tested messages in a random order while controlling for the content, which means we only use tested messages, and also we randomize the order, and also we control for costs used for each campaign message, and also we control for the days of ad promotion. We ran each advertisement for about less than 7 days. And we also geo-target the message exposure, targeting rural versus urban areas by using zip codes. And this is a snapshot of how those social media campaigns look on somebody's Facebook news feed. For people who are interested in taking the survey, they click, and then they also directed to an anonymous confidential survey asking further questions about their perception and attitudes and their behavior intention to vaccinate their children against HPV. So there was also a way to measure this campaign through online surveys. And to measure the effectiveness of campaign, we extracted data, ad performance data for each campaign message. So for advertisement engagement data, we extracted numbers for reach impressions and the rates and link clicks and page engagements and etc. And we are currently in the process of preparing for data analysis for this phase 3 campaign. So I just showed you how we use different studies within social media environment for widespread of campaign messages on HPV vaccination. As I said, social media provide benefits and opportunities, but I think these media environments can be even stronger when we translate research scientific method and also research principles. So in this study, we really utilize principles from persuasive technologies, utilize best tactics from health communications, and also we target social and health psychological constructs. And also the reason why we conducted this study is to really understand the science of behavior change. So this study showed the multi-phase sequential designs starting from the environmental scan through focus groups, message testing, and also real-world social media campaign. So that was it for today, and I would like to acknowledge my colleagues at Dartmouth, Dr. Arlis Olsen and Jenna and Inger Imstedt, and also like to acknowledge the funding source of the project. And if you have any questions, I will be happy to answer after this talk or through my emails. Thank you.
Thank you for your presentation. We will now move to the Q&A section. Ellen, Rachel, and Sunny, please unmute your videos to begin.
So first, I'd just like to thank Dr. Baker, Dr. Weiner, and Dr. Kim for the excellent presentations. Just some reminders to the audience about how you can participate. The chat feature will be disabled during this segment, so please don't use that. However, you can use the raise hand feature, which is located at the bottom of your screen, to indicate that you have a question or comment, and then we'll enable the audio so that you can speak. You can also ask questions and place comments in the Q&A text feature, which is also located at the bottom of your screen, and we already have several questions there. Just so you know, we'll try to go to the raised hands first for your inputs, and then go to the Q&A text. We'll try to get to all your questions, but since we have almost 800 participants on at the moment, we may not be able to. The other thing to note is just that you may be asked a few polling questions to help structure the discussion, and you'll see a pop-up window that'll appear at your screen. We have about 15 minutes for questions, and then we'll have a break from 2 to 2:45, but just so that everyone knows, we will have another session starting at 2:45 to talk about underserved communities. So if we don't get to all the questions now, there still is that second option. I don't know, Jasmine, if we have any hands raised.
We did, but I think they're taking back their raised hand. We can probably move on to the actual Q&A section.
Okay. One question sort of for each of the presenters that was asked is, what do you see as the biggest challenge at the moment related to cervical cancer prevention, HPV? Maybe we can start with Dr. Baker.
Thank you, and I really enjoyed the presentations from the other two panelists. Thank you so much. You know, here in the US, we have all the tools we need to eliminate cervical cancer. More broad reach of screening and ensuring that women with abnormal screening tests receive treatment, and then ramping up vaccination. And I think it was Rachel's presentation where she mentioned that 25% of women are under-screened. So to me, that is the great challenge, is to get everybody in for screening and treatment, make sure we don't lose anybody with a positive screening test, to make sure they get the treatment they need, and then continue to improve our vaccination rates. And together, this should eliminate cervical cancer in the US. It'll be more challenging in low-income countries where all the resources are not available, but the basic strategies will remain the same.
Great, thank you, Ellen. And Dr. Weiner?
Hi, and I'd also like to echo that I appreciated the other two talks and being able to be part of this panel. And I would echo what Dr. Baker said as well. We have the tools to prevent cervical cancer. We really just need to get them out there. So scale up of vaccination and screening, and particularly in other parts of the world in settings where it's just been so difficult to get women screened. Trying to scale up vaccination programs could have a really huge impact.
Great, thank you. And Dr. Kim, what do you see as the biggest challenge?
Yeah, I really enjoyed other two presentations, and yeah, I agree with both of you. I think there are environmental constraints, but I think some of the barriers are within person. So, you know, there are external barriers, but also within person. I think some people do not have enough knowledge or do not have enough resources, or may have different, you know, risk perception, underestimating the risk later because they don't see the bad consequence right away, but it's something, this is something that is more like a long-term risk, maybe a long-term risk, especially for people who are younger age groups. So I think some of the barriers are really on countering misperception, also disseminating the information, right information to people who are, even for the, you know, underserved population, underserved communities.
Great, thank you. Dr. Weiner, there are several questions in the Q&A box about asking whether or not the home HPV testing is currently commercially available, and if not, when you think it may be, and the cost.
Yeah, so that's a good question. So self-sampling kits are available in some other countries like Australia and the Netherlands, and they're being used routinely. In the US, it's possible to use a self-sampling kit. The big barrier in the US is that we don't have an FDA-approved self-sampling kit. You know, individual labs can validate self-collection devices and assays for use in their own labs or clinics, but there's not an FDA-approved device. The National Cancer Institute is actually planning a large trial to get data on efficacy of self-sampling in the US that can be used to apply for an FDA application. So hopefully that is the data that would be needed to clear that final hurdle of getting the FDA approval. And maybe that will happen in a few years, but right now there's not a specific kit that is FDA approved in this country.
It looks like we have someone with their hand raised. Penny, I'm going to go ahead and allow you to talk. You may need to unmute your own mic.
Go ahead, Penny.
Okay, so I was in the Peace Corps in Uganda, and they were doing a push for screening for cervical cancer. And at the time they were using, it was like a vinegar swab that they were using to check for lesions and pre-lesions within the cervix. I was just wanting to get the opinion of some of the panelists on if you know, that's something that they would recommend in the resource communities, or the effectiveness, or what they feel about that type of testing, since the laboratory resources are very limited there.
Ellen, do you want to take that one?
I could take that, or you could take that, Kathleen. Would you like to take that?
No, go ahead.
So VIA is visual inspection with acetic acid. It was a method introduced about a decade ago. I think it first came out of India as a low-cost screening method. And when you place vinegar on the cervix and let it sit for a minute or so, the cells that are abnormal will turn white. And so we are able to see immediately if there's an abnormal area on the cervix, and then treat it immediately. So it was a one-visit sort of see and treat strategy for doing low-cost screening. In the subsequent 10 or more years that it's been used, primarily in low-income countries, it hasn't quite measured up to what we had hoped. There's, I think there's a lot of false negatives and false positives, and it requires a little bit more skill than we had expected from the provider. It does require a speculum exam and somebody who's fairly knowledgeable to be able to interpret the result. and then to be able to provide the treatment right there. But it is still very widely used. If you remember at the end of my presentation and Rachel's presentation, we talked about the WHO call to action. And WHO is recommending a very sensitive, high quality test, which is an HPV test, as a better method to do screening. So VIA is still used around the world. Its efficacy in identifying women with pre-malignant lesions is a little plus and minus depending on what you read, and the ability of this method to reduce the incidence of cervical cancer has been somewhat mixed, but it is still widely used. Maybe you have something to add, Kathleen.
No, I think that's a great explanation, and we'll talk more about this in the 2:45 session about cervical cancer screening and prevention in underserved populations. Are there any other hands raised?
Yes, we do.
Okay.
Dylan, I'm going to go ahead and allow you to talk. Please unmute your mic.
Yes, can you guys hear me?
Yes.
Awesome. Yeah, so my name is Dylan. I'm a health educator at Fred Hutch in Seattle, Fred Hutch Cancer Research Center, and my question is for Dr. Kim. Great presentation, and I apologize, the last part of it actually froze for me, so you might have already addressed this, but as far as using social media and working with rural communities, which is what I do, I just wanted to know if Dr. Kim could just reiterate, would you recommend that, and was that successful for you in working with those populations?
Yeah, thanks for the questions. Yeah, I think overall, I would say yes. People may have the common sense, like it might be hard to reach out to people, especially in rural areas. But actually, it was counterintuitive for us as well. People living in rural areas, the penetration rate of having mobile device or having social media accounts is very high. So yeah, for us, we learned that using social media was actually very beneficial, especially for reaching out to underserved populations or people living in rural areas. And when we look at in another study that we also targeted people living in rural areas, we learned that people, when we look at where they're coming from in another study, we also measured their zip code, and we found that people living in very isolated areas, they also participate in those online survey or online experiment. So I think, yes, media can actually leverage those geographical barriers.
Thank you, Dr. Kim.
All right, we have another raised hand. Christine, I'm going to go ahead and allow you to talk. Please unmute your mic.
Yes, I have two questions, if I may. The first question is, I am 45. No, I'm not. I'm sorry. I'm 44, almost 45. And can I or should I have a vaccine after exposure?
Ellen, do you want to answer that one?
So the vaccine was recently approved up to age 45 in men and women, but the recommendation is to discuss with your healthcare provider whether or not it would be a good idea for you to receive the vaccine, what your actual risk is based on your health exam and your history, and then you and your healthcare provider make a decision together. It is recommended for the preteens up to age 26 and boys and girls. It's approved up to age 45, but for those of you in the 30s and 40s, it's a joint decision that you make with your healthcare provider, looking at all the evidence, all the data.
And what type of specialist would I go to for HPV other than a general gynecologist? Is there a specialist, or what type of doctor would best be able to help me with HPV?
It would be an exam, a gynecologic exam, and somebody familiar with the subject, and I would say a gynecologist or a general internist or family practice doctor who's fairly adept and familiar with the information, the data, and the decisions.
Okay. And lastly, if your body clears the virus, can it come back from that same exposure?
I can come up with an answer for that. I'm not sure it's the right answer. Kathleen, do you have a good answer for that?
Yeah, so one thing to remember is 80% of people are exposed to HPV, if sexually active people are exposed to HPV at some point in their lifetime. And so almost everyone gets HPV, but very, very few people go on to get cancer. So it can persist, you can be reinfected. And so obviously in the clinic, we get these questions all the time. And there were many questions in the Q&A box as well about that. And so that's the reason that we really try to vaccinate kids before they become sexually active and before they're exposed to HPV, because that's when the vaccine works. So there were also a lot of questions about if I tested positive, most people clear it. Most people immune system clears it. And then the question is, you know, are they reinfected or was it lying dormant and reactivated? And a lot of that is not, in each case, is not entirely known. But what we do know is that once you've been infected with certain types of HPV, the vaccine won't work against that type of HPV once you've had it. But the vaccine may work against other types you haven't been exposed to, because as Ellen said, there's 9 types of HPV that the vaccine works against. So that's the confusion about, you know, should you still be vaccinated? And the answer is yes, if you're up to age 26, because it may be that you haven't been exposed to certain types. But again, the ideal is that we vaccinate kids prior to being exposed to any HPV, and again, both boys and girls. And again, just back to the 26 to 45, although it's FDA approved, most people at that point have been exposed, and you still are required to get screening after HPV vaccination. So sort of the effectiveness, the high cost, the shortage of vaccine, all those play into it, which is why we look at each individual and recommend a discussion with their doctor about it.
Okay, thank you very much. And if you come back again. Okay, thank you.
Great. One question that has come up over and over in the Q&A box is about screening for men. Again, we recommend the vaccine for boys, and as was stated in the different talks, that HPV also causes oropharyngeal cancer, anal cancer, penile cancer. However, there's no screening for these cancers in men. Unfortunately, we don't have the equivalent of the Pap test or colposcopy for oropharyngeal cancer. And so there are many studies going on at the moment to develop screening tests for men, including one here at MD Anderson called the Houston study. But unfortunately, there are no recommended screenings at the moment for men outside of clinical trials. Even if you did an oral rinse for HPV in men, there's no colposcopy, or there's no follow-up diagnostic test for that. So it's not recommended outside of a clinical trial at the moment.
Okay, we have another raised hand. Jacob, I'm going to go ahead and allow you to talk. Please unmute your mic.
Hi, I just had a really quick question, just a little background on me. I'm an intern with Penn Quarter Partners, a consulting firm that works in healthcare and pharmaceuticals. Just a really simple question for anybody. I was just wondering what some best practices might be when it comes to raising awareness, public campaigning, topics like that. You know, what any of y'all would recommend in terms of what to do, practices, things like that.
Dr. Kim, do you want to take that one?
Sure. When it comes to campaigns, some of the challenges that well-known challenges are measuring the effectiveness, but also some of the challenges are coming up with the effective messages and also disseminating in an effective way, which means like not only the persuasiveness, also for the cost effectiveness. When you think about the marketing plans for like commercial companies, they are very successful for their campaigns. When you think about the like marketing, like even like other unhealthy products, but I think some of the marketing tactics can be used for public health campaigns. The method can be used. One of the methods that people use in marketing is integrative communication approach. So you are not only using one type of media exposure, but you are using multi-pronged media outlets to deliver messages in an effective manner. So that is really a great question. And also there are a lot of work to be done for public health campaigns. But yeah, I think one way to answer your question quickly, I think one way to really think about how we can deliver or implement and disseminate effective campaigns, some of the method and the principles and also the approaches can be leveraged from those marketing or communication studies.
Great, thank you. We are over time, so we're going to stop now. I'd like to thank our speakers, Dr. Baker, Dr. Weiner, Dr. Kim, for their excellent presentations. And just a reminder that we will resume at 2:45 Eastern time for the peer conversation, meeting the needs for cervical cancer screening in underserved communities. So thank you all for your participation and for all the great questions. And we hope to see you in about 40 minutes.
Thank you.
Thank you.